The fetal skull. What is it? Which parts make the fetal skull? What bones are on the fetal skull? Which diameters are on the fetal skull and what are their significance? What are the landmarks and regions found on the fetal skull? And of what significance is the fetal skull on the fetal body and to midwifery studies? So good afternoon everyone, it's your midwife again, Theo the Good Midwife, and today we're going to talk about the fetal skull as per the request of student midwives. So the fetal skull is the largest, the hardest, the more resistant, and the less compressible part of the fetal body. It is a very important part in midwifery because 90% of deliveries are cephalic, which means the head presents in most cases of deliveries. Hence, the midwife should have knowledge about the fetal skull in order to detect abnormalities and prevent complications. So, what are the parts of the fetal skull? The fetal skull is made of the base. The base is beneath the fetal skull and is made up of ossified or hardened bones. It supports the fetal skull and protects the brain. There is the face. The face is run from the point of the orbital region, that is here, to the point where the chin meets the neck. And the face is made up of 14 compressed bones or ossified bones, and it also has some orifices, talk of the orifices of the eyes, the nose, and the mouth. We also have what is known as the vault. The vault runs from the point of the orbital region and is the dome-shaped part. It also consists of the vertex, normal vertex delivery, up to the point of the nape of the neck. So these three are the parts of the fetal skull. So let's talk about the vault, since most deliveries are vertex deliveries. The vault is made up of bones. Which bones make up the vault? I'm sorry I'm not an artist, but I tried to come up with something here. So we have two bones called the frontal bones. They cover the front of the fetal skull. We also have what are known as the parietal bones. But before we go any further, these two frontal bones, their ossification areas are known as the frontal eminence. Guma. Then we move on to go to the parietal bones, and their ossification areas are known as the parietal eminences. We also have what is known as the occipital bone. The occipital bone covers the back of the head, and the area of ossification is known as the occipital protuberance. So the occipital bone is also important because it covers part of the area known as the foramen magnum. Dopa area panopinda ne spinal cord from the head ishinsik. So it's also equally important. So let's talk about the sutures. The sutures, these are areas of membranous tissue where ossification hasn't taken place. Sutures are very important. Where ossification hasn't taken place. So how many sutures do we have? A suture is an area where ossification isn't taking place and it divides two or more bones. So we have what is known as the frontal suture here, running from the point here up to the bregma. Tingangot irukubva pa the point of the what? Of the orbit. Up to the point of the what? Of the bregma. And it's dividing two bones, which are two frontal bones. And we also have what is known as the coronal suture. The coronal suture divides the two frontal bones from two parietal bones. And we also have what is known as the sagittal suture. The sagittal suture divides two parietal bones. We also have what is known as the lambdoidal suture. The lambdoidal suture separates the occipital bone from the parietal bones. So these are the sutures that we have. Now, we also have what are known as fontanelles, and significantly we should talk about two fontanelles. We have what is known as the anterior fontanelle and the posterior fontanelle. Anterior fontanelle, which assumes the name bregma, and the posterior fontanelle, assuming the name lambda. So a fontanelle is an area where two or more sutures meet. So we can now look at the anterior fontanelle, this one. The anterior fontanelle is kite-shaped or diamond-shaped, and in this anterior fontanelle runs four sutures, which are, we have the frontal suture running through the anterior fontanelle, we have the sagittal suture, we have the coronal suture on either sides. This suture should close by at least 18 months. This fontanelle should close by at least 18 months. Then we move on. We now have the lambda. The lambda, better known as the posterior fontanelle. The posterior fontanelle has the what? The sagittal suture running through it, as well as the lambdoidal suture on either sides running through it, and it's triangular shaped and small, and we expect it to be closed by 6 weeks. So these are the sutures. They are also important landmarks on the fetal skull. So let's move on to the regions and the landmarks of the fetal skull. Unfortunately, I'm not an artist, but I tried to draw something. I hope you appreciate. So here we are. We have this whole skull here, and we now want to talk about the landmarks and the regions. Here I've marked from the point of the orbital region up to the point of the bregma. There is an area known as the sinciput or brow. And we also have what is known as the bregma. We've talked about it, which is the anterior fontanelle. This one is a region, but the bregma is a landmark. A landmark is an area you could tombo turukuita for general examination. Ukapinda. Ukaibata, you can actually realize what I know Ijin Chandabata is an anterior fontanelle. And then we have what is known as the vertex. The vertex is a region which runs from the bregma here up to the point of the lambda and is bound by the parietal bones and the eminence. The vertex is important because ndio part yatrikuti in normal delivery ndio part inenge chidi ichipresenta. That's the vertex here. Now we also have what is known as the lambda, the posterior what? Fontanelle. It's a landmark. We have what is known as the occipital region. Occipital region from the point of the lambda here, cover up to the point of the suboccipital region, somewhere around there. It's a bone and an area that covers there. Then from there we have what is known as the suboccipital region. Suboccipital region is the area beneath the occipital protuberance, the area of ossification of the occiput. So that's the suboccipital region. We have another landmark here known as the mentum. The mentum is just the chin. Then we also have the glabella. The glabella is the bridge of the nose or the area between the eyes. Here, that's the glabella. So these are the landmarks and regions of the fetal skull. Let's move on to talk about the diameters of the fetal skull. The fetal skull has about my longitudinal diameters. So we have what is known as the suboccipital bregmatic. Suboccipital bregmatic, which means it's coming from the suboccipital region up to the point of the what? Of the bregma. So it's somewhere here below the occipital protuberance, and it runs up to the point of the what? Of the bregma. Saka area inenge present apa the E, and the suboccipital bregmatic diameter is 9.5 centimeters. We also have what is known as the suboccipital frontal. Suboccipital frontal is 10 centimeters, but other versions are not 10.5 centimeters. So it's suboccipital, that is below the occipital protuberance, up to the frontal suture. That's the suboccipital frontal diameter. This diameter has any significance yacho, and kana ichipresenta area inopresenta ndeyese ishi iri apa ishi. Andika. Now we also have the diameter known as the occipital frontal. Occipital frontal is running from the occipital protuberance up to the point of the glabella, and the occipital frontal is 11.5 centimeters. And the area inenge ichipresenta area yose yemusoro isho. Anditka. Then we have other diameters. We have what is known as the submentum brachmatic. Submentum brachmatic is from the area where the neck meets the chin. So that's submentum brachmatic. Brachmatic up to the point of the brachma, that's 9.5 centimeters. We also have what is known as the submentum vertical. Submentum vertical to the point is from the point where the chin meets the what? The neck, up to the highest point of the vertex. Saka submentum vertical is also 11.5 centimeters. We have an area and a diameter. The widest diameter here, the longest diameter, is known as the mentum vertical. Mentum vertical is from the point of the chin up to the point of the highest part of the vertex, and that diameter is 13.5 centimeters. What is the significance of these skull diameters? Right. Let's talk about the suboccipital brachmatic. Suboccipital brachmatic is 9.5 centimeters, which is here suboccipital brachmatic covering the occiput. And at the same time, inengage mechana a diameter inonzi biparietal, which is a transverse diameter, which is also 9.5 centimeters. This is a diameter present in all occipital anterior position. And the left occipital anterior, the right occipital anterior. These are the normal labor positions or delivery positions. And so because make up 9.5 centimeters of that suboccipital brachmatic plus biparietal diameter, bayagadzira a circle, chikotsi chine circle, chagadzira a circle. And that rounded part ndo iri kuenda yonoraunda even pa cervix, and this part inoita kuti labor iprogresse zvakanaka because there is well application of the cervix to the presenting part. In this position, the head of the fetus is well flexed. Kana chiti well flexed kuti the chin is meeting the chest, something like, and the part that presents is the occiput and a smaller diameter, which means labor progresses well. That's the significance. Then we have what is known as the suboccipital frontal. Suboccipital frontal, tati susu, iri kubva from below the occipital protuberance up to the point of the frontal suture. Suboccipital frontal significance yayo ndeyekuti is also an engaging diameter in occipital anterior position. But however, this time the head is not well flexed. Pekutanga that the head is flexed, but this time the head is not well flexed. Neither is it deflexed, because deflexed is military, wakamira anditka. But panapa is not well flexed, saka it's somewhere in between, something like that anditka. So it's also an engaging diameter kana musoro usina kunyatso flexa. However, as labor progresses shakanaka, with the effect of contractions hitting the spine and the occiput yemwana, eventually mwana anoguma musoro yemwana anoguma wapinda muchi suboccipital brachmatic position, wobva wa reducer wodzokera kuchi ku 9.5 centimeters as labor goes by. And it also, this suboccipital frontal is an important diameter because it is the diameter that distends the vulva or the vaginal orifice when extension takes place after crowning. And it mwanano crown the birth of the biparietal diameter, and then they extend their head over Buddha. The diameter that distends the vagina or the vulva is the sub-occipital frontal diameter. Then we want to talk about the occipital frontal. Occipital frontal diameter, yatati is 11.5 centimeters, running from the occipital protuberance to the clapella. It's quite long. Occipital frontal significance ndeyekuti ndiyo diameter iri kuengage nayo mwana in a deflexed position. Mwana anenge akadeflex akamira kadai. It's military. And usually this diameter is associated with occipital posterior position. So this is the diameter in engager in occipital posterior position. Our normal positions zvatinoshuvira in labor is occipital anterior. But this time, mwana engage in the occipital posterior position, which means there should be something wrong with this pelvis. Maybe it's an android pelvis. Mwana aina nekupi, aina nekumasure. So, iwe ukaziva kuti pauri kunopalpata, of course, pauri kunotanga kubata kudeo. Secondly, nepauri kunoita vaginal examination. How do you tell kuti this is an occipital posterior position? Firstly, the fontanelle that you access to is the anterior fontanelle. And I want to remind you kuti in the occipital anterior position, but that sub-occipital pragmatic. Ukaita VE, the fontanelle yauri kunobata ipapo is the posterior, because anenge akadai. Saka uri kunobata fontanelle yokumasure. But with this diameter occipital frontal, that is associated with occipital posterior position. So the fontanelle yauri kunobata is the anterior fontanelle. And zvakutongokudza kuti mwana uyu ari kuuya in an occipital posterior position, and it's associated with what? It's associated with prolonged labor and severe pain. Amai vanorwadziwa zvekuti be. Prolonged labor in what way? Nekuti pari kuda kuti rotate 3/8 of a circle. Nditika. Saka mai vacharwadziwa zvikuru, labor ichati rebei. So you have to reassure and do pain management. Ndiwo uri kunyora ipapo pa significance. Pain management in labor, pharmacological and non-pharmacological pain management in labor. Anditi. More so, I diameter yatiri kuti the occipital frontal ndo iri kuzono distenda the vagina or the vulva kana ikaramba yakadaro. That is face to pubis. Anditi. Kana pakaitika position yekuti face to pubis hapana kuitika internal rotation, long internal rotation. Anditika. Nyaya iripo ndeyekuti iyo ndio iri kuzono distensa the what? The vulva. Kana zvadaro, this is also associated with lacerations. Saka iwe uri kufanira kugara wakagadzirira kuti mwana anogona kuuya asingakwani. And to avoid lacerations, I should perform an episiotomy. Obva wakura. So it's a significance yaunenge watotaura ipapo. However, occipital posterior position kana kaita long rotation kazhinji kacho ari kuzonozvarwa ake ava muchi sub-occipital pragmatic position. Then we have what is known as the submental pragmatic. Submental pragmatic is the diameter yatiri kupresenta nayo kana mwana ari kuuya ari mu first presentation. First presentation, submental pragmatic. Then you also have to prepare kana uchizoti ndo iri kuuya. And imwe nyaya iripo ndeyekuti wominimize vaginal examination kuti unodi unokuvadza mwana kuneso. That's the significance. Then we have what is known as the submental vertical. Submental vertical zviri kungoreva kuti the head is not extended, is not well extended. In submental pragmatic, the head is well extended. The occiput is meeting the back. Pari kuya neface, occiput yake rinosangana nechi neback anenge akatarisa mudenga so. But pa situation ye submental vertical is neither extended kana kuti yakamira. Saka iri pakati nepakati. Is not well extended. That the submental vertical end is 11.5 centimeters. Also, this diameter my first presentations ndiyo iri kuzono distensa the what? Iri kuzono distenda the vulva and the vaginal orifice. Then we have the position, the diameter known as the mento-vertical. Mento-vertical is from the point of the mentum to the point of the highest point of the vertex, 13.5 centimeters. Here, delivery is impossible, and usually engagement doesn't take place. Saka ushinge waona kuti panapa pane difficult, mwana asikunya pari difficult, mwana asikutoengage, musoro ukuramba uri kumusoro, theater please, because hatizvarisi sinsiputi or brow presentation. So what is the significance of the fetal skull to the midwife? Firstly, inotidzidzisa kuti mwana aengage, musoro waengage. Tinototarira in the final weeks of pregnancy kuti musoro wakudi wakuburuka. By merely palpating, midwife anenge akuziva kuti no, the head is now engaged, and you should give advice accordingly to this woman kuti no, she prepare mazuva enyu akudi akuswedera, labor and delivery is nigh, mabhegi enyu chigara makadi makapfeka. Then the other thing, inotidzidzisa pamusoro pechi progress of labor by the head. Ma-contractions anogona kunge ari right, but iwo uchitoona kuti musoro hausi kufamba, the descent is poor, the level of presenting part iri kuramba iri stagnant, ichita kunge yakakepchiwa kumusoro. So inototudza kuti no, labor progress yakadhakwa, maybe panogona kunge pane obstructed labor. Musoro wemwana uri kudzidzisa, unokudzidzisa even diagnosing ma-conditions akaita sana first presentation. Kana ukaziva kuti pane first presentation, iwewo wakuziva kuti wakuminimiza ma-vaginal examination ako kuitira kuti usazokuvadza mwana kumeso. Mwana anobuda akadi akasvimba. Moreover, anokudza about the position yemwana. Iwe uri kutoziva kuti this is a posterior position, hence pane prolonged labor and pain. Kana ukaziva izvozvo, pain management, pharmacological and non-pharmacological, and reassuring this woman. And anokuudzawo futi about normal positions. The other thing ari kukuudzai about molding. Molding, excessive molding, pauri kunopinda udeo mabhonzo asi kurijusika, pauri kunocheka on vaginal examination, mabhonzo acharijusiki, and paitika excessive molding, which means pane obstructed labor. Midwife akangwara akubva afonera machiremba takuenda ku C-section nekuti pane obstruction. We have prevented obstruction nekuda kwekuti uri kuziva kuti musoro wemwana wakambomira sei. Caput, wakutodzamai kuti musapusha nguva yekupusha isati yadi yakwana, nekuti watonzwa kuti musoro wakadi, musoro wakasvimba. Moreover, inogona kuva caput iri due to cervical dystocia. Musoro uri kungorovera pa an unyielding cervix, hence is an obstruction. Chiudza ichiremba kuti timhanyire ku theater. You can also diagnose mamwe conditions akaita even sana hydrocephalus. We all know kuti size yemusoro yemwana inofanira kunge yakaita sei. Iwo pauri kutonobata nyange pasina scan utonzwa kuti this head is big. Wakutotumira mukadzi for further investigations kuti imbonoendai kuscan kuti mbonoti zvakamira sei. With hydrocephalus hatisi kuzovapushisa, vakuenda kupi, vakuenda ku theater. Anacephaly, you can actually diagnose them. Uchinopinda kudai uona kuti musoro uyu hameno zvawakaita, is not as hard as the head should be. Hence wakutoita zvinoita kuti amai vaende kunochekwa, because in anacephaly mwana afanira kunge achipushwa. Those are some of the things dzaunomenshena kana uchitaura about the significance of the fetal skull to the midwife. So I hope this helps, and pamusoro pezvimwe zvamuchazoverenga nezvamuchawedzererwa kuchikoro. I hope the fetal skull were done. Thank you.